There you go. Okay, good afternoon. It's a great turnout. Welcome on this wonderful but windy Valentine's Day. Nothing gets your heart aflutter than talking about pancreatic cancer. We are very, very fortunate to have Dr. Karyn Goodman address this really interesting and important topic. It's a topic sometimes that many people outside of the radiation oncology field don't really know a lot about. This is your chance to really learn about how it's becoming practice changing, not just in pancreas, but throughout the body. Dr. Goodman did her undergraduate and medical school work at Stanford University, and then did a actually fellowship at the CDC in reproductive health, and then followed that up, and she was beginning to explore what she was going to do next. Her residency in radiation oncology at Memorial Sloan Kettering, where she was the chief resident at the end of her training career. As if that wasn't enough, she also got a master's in epidemiology in the Harvard School of Public Health in 2006. And since that time has built really a remarkable reputation around the world, not just nationally, in her expertise in GI cancers, really formulating an expertise and a focus on intensity modulated radiation therapy, stereotactic body radiotherapy, and also, importantly enough, the quality and outcomes and late effects of radiation to areas like the esophagus, the pancreas, the rectum, and really informing the community around the world on how best practices should be. Importantly, she is also the PI on a phase 3 trial in post-op pancreatic cancer. Needless to say, that's an incredibly controversial area, and also was recently presenting at the ASCO GI on some very interesting results in her as a PI on a phase 2 trial through the CALGB and the Alliance Network on esophageal cancer and the use of PET to try to determine which route to go in regards to chemotherapeutics. So she's joined us after 8 years at Memorial Sloan Kettering and is Associate Director of the clinical research here, and has been here approximately a year and is already thundering through and really energizing the GI group. And we're very, very fortunate to have her here, and I'm fortunate to have her as a colleague here.
Great, thanks, David. He's always the most convincing person I know, so nice to have him give a introduction. So I'm going to be talking a little bit about some of the new options and new techniques that we have for treating pancreas cancer. And just as a side note, it's one of those things that I've been doing for a long time, but it's starting to have a little more personal impact on me. And as of right now, I have an uncle that's now has metastatic pancreas cancer, and a good friend from my freshman dorm at Stanford who has metastatic pancreas cancer. So it's interesting how over time, you know, we hear about it as physicians, but you know, when it hits home, you start thinking about how can I really improve things. So I've been thinking a lot about this over the last several months especially. So I'm going to talk a little bit more about our new technologies and some of the new ideas about how radiobiology plays a role in how we can treat pancreas cancer. So I'm going to start by just giving a little overview. I know I have a great turnout from the radiation oncology department, so thanks guys for coming. And but I know many of you are not necessarily directly involved in the care of pancreas patients. So talk a little bit about the problem, the management of pancreas cancer in general, then talk a little bit about some of the clinical trials for radiation therapy in pancreatic cancer, and then specifically looking at some of the emerging data in the use of stereotactic body radiotherapy for pancreas cancer, and what are some of the technical challenges BRT in this setting, and then finally some new and exciting directions that we're going in. So this is kind of a depressing slide. This is the number of cases, 53,000 cases diagnosed in 2017, and about 43,000 die of pancreas cancer. So while it's not one of the most common cancers that's diagnosed, it is the fourth leading cause of cancer mortality for both men and women. And unfortunately, there is a slow rise in the incidence, as you can see here. This is just pulled off the SEER website. The incidence has been rising slightly over the last 30 years, and we really have had sort of a flat line in terms of the mortality rate. We're not seeing much of an improvement. And this is even better shown here. These are all of the different types of cancers and the 5-year survivals for the different types of cancers. And you can see for many of the other cancers, they're usually in the double digits and have improved over time. Here we have pancreas cancer with a 5-year survival of anywhere from 2 to 6%. I think this is up to 2008. The estimated 5-year survival in 2017 is about 7%. For all comers. So we're not doing very well, and we haven't seen a lot of improvement over the last 30 years. One of the things that is, part of the issue here is that we don't diagnose patients early with pancreas cancer. So the vast majority of our patients have metastatic disease or what we call locally advanced disease, meaning that the tumor is involving the vasculature in the abdomen and can't be removed surgically, but there's no evidence of distant spread at the time of diagnosis. So practically 80% of our patients are in a situation where they can't undergo surgery, and only about 20% of patients are able to undergo an operation. And for those patients, even with resectable disease, the median survival times are only about 2 years. For locally advanced, it's about a year, and for metastatics on the order of about 9 to 12 months. Since not everybody knows the abdominal anatomy very well, I just wanted to describe a little bit about where the pancreas lies, what are the blood vessels nearby, because that really determines how we can treat these patients. So these are just some cross-sectional images to give you a sense of how the location of the pancreas and where the tumor is impacts on our ability to do surgery or to do even radiation therapy. So this is a normal pancreas, and you can see it's this is a glandular structure. There's nice black fat around the pancreas. It had this little tiny, very thin duct that goes through it. And the pancreatic head sort of wraps around this blood vessel called the superior mesenteric vein, and then you have the superior mesenteric artery right next to it. And this is the duodenum, and that head of the pancreas actually sits in the C-loop of the duodenum. So that's not such a big deal for surgery because they remove that, but for us, when we're doing radiation, that can be a limiting factor because of the radiosensitivity of the GI tract. But these blood vessels are what are an issue in terms of whether we can do resection. If they're involved, that can impact on the resectability. This is a tumor of the pancreas. So this is a little bit of normal pancreas here. It's a little bit brighter, but this dark area here is hypointense, and that's where the tumor is. And this is, again, the duodenum. You can see that the tumor is right up against the duodenum. There's barely any interface. This is our superior mesenteric vein, our superior mesenteric artery, and there's this little fat plane right there. It's black between the tumor and the vessel, and that means it's resectable. So on this particular slice, this would be a resectable tumor, and this patient could go to surgery. Then things get a little bit more difficult when there starts to be tumor. This is another cross-section through a patient who with pancreas tumor. This is the pancreatic duct is dilated. Here's tumor right here, and this is the SMV. And this tumor is contacting right around the SMV, and if you were to scroll up and down, you could see it's just over about 180 degrees around this SMV. And so this patient has a borderline resectable tumor because you can technically remove the SMV, but you can reconstruct parts of the SMV, but it makes it much higher likelihood that this patient may end up having positive margins. And that's really what the surgeon wants to determine as to whether when it's resectable, they can take it out and not leave any tumor cells behind. And here's another tumor. This big mass here is all tumor, and this is our SMA, and it's pretty much wrapping about 270 degrees around that SMA, and we can't remove the SMA. So this patient is considered unresectable. The other word that we use is locally advanced. There were no evidence of distant mets. So that really determines how we manage patients with pancreas cancer based on that resectability. A lot of cancers, we talk about the AJCC staging system. This sort of correlates with that to some extent, but for the most part, we think about patients as having either metastatic disease, and the primary treatment for them is chemotherapy, resectable disease, which the standard has been upfront surgery followed by chemotherapy and then chemoradiation, but there's been some question about that chemoradiation component, and we'll talk about that in a little bit regarding whether there's any role for it. Now we're starting to see more and more doing upfront therapy before surgery, even in resectable patients, and I'll talk a little bit about that in a minute. Then we have the locally advanced patients, where generally the approach has been to give chemotherapy and then possibly chemoradiation, although that's been questioned with a recent study that I'll talk about. And now the idea is potentially doing more SBRT in this setting, because this may be a nice option for patients to have a shorter course of therapy. And again, I'll go into that in more detail. And then we have this group that's sort of been defined over the last 5 years or so of borderline resectable patients. This is kind of this gray zone, and we have some definitions for it. I'm not going to go into detail about, how many 180 degrees around the vessel is, that's, the definition in terms of the vessel involvement. But suffice it to say, this group of patients are really the ones that the surgeon feels they could technically do the surgery, but have a high likelihood of leaving tumor cells behind. So in this group of patients, more and more, we're thinking about doing neoadjuvant therapy with either chemotherapy or chemoradiation or even SBRT. And we here at University of Colorado, we're primarily using the option of chemotherapy and SBRT. So I'm going to move on to talking about some of the clinical trials using radiotherapy for pancreas cancer, and not go too far back into history because there have been a lot of studies over the years that are quite old, but I'll talk a little bit about some of the more important ones. So in patients, so what really is the goal of radiation for our patients with pancreas cancer? So in the group of patients that are going to surgery, the resectable patients, it's really to address any potential micrometastatic disease that may have been left behind after the surgery in the lymph nodes, at the resection margin, with the goal of preventing local recurrence. In the neoadjuvant setting, it's sort of the same idea. It's almost trying to sterilize the margin or potentially address any cells that might have been left at the margin when the surgeon is taking out the tumor. For borderline resectable patients, the goal is to convert them to being truly resectable patients by shrinking the tumor down, moving it away from the vessels, or at least sterilizing that edge of the tumor right up against the blood vessels. And then finally, for the locally advanced patients, the idea was really to address that local disease burden. You can imagine having a mass in your abdomen right up against the intestines, back in the back of the abdomen, up against some of where the celiac plexus, your nerves come out. It can cause a lot of pain, obstructive symptoms, so potentially addressing some of those symptoms related to the tumor. And then finally, in a very small percentage of patients, we can actually convert them to resectability by shrinking the tumor down. So I'll start talking just a little bit about resectable pancreas cancer. And this is a curve that was given to me by one of the surgeons I worked with at Sloan Kettering, showing the results of surgery for patients with pancreas cancer. This is from 1983 through 2006, almost 1,000 patients. And you can see that the 5-year survival, even for the 20% best players, the resectable patients, it was only about 18%. So not very good. And the median survival for patients was under 2 years. So this really set the stage that we needed additional therapy. Surgery is not enough. So for many years, there were studies looking at giving adjuvant chemotherapy and radiation together. So long course chemoradiation, usually usually they were doing it as a split course. They'd do 4 weeks, but split it up into 2. And with a very old drug, 5-FU. Which was sort of the tried and true. So these older studies had some, initially the first study showed that there was a benefit to giving the adjuvant chemoradiation in terms of survival versus those that were just observed. But then there have been some subsequent studies that have called into question that benefit. So this was still quite a controversial topic, and in fact, it was actually quite different depending on whether you lived on one side of the Atlantic versus the other, because the GITSIG trial is an American study, and the EORTC and SPAC trials were both from Europe, and both of these studies were negative studies. So it really brought us into this question: is what's the right route to go in terms of adding chemoradiation after surgery? I don't want to go into a lot of detail about this study, but I just wanted to show that there have been ongoing studies. This is a U.S. study that was looking at adjuvant chemotherapy plus radiation, and the question was actually which chemo to give. It was 5-FU versus gemcitabine. And the reason I'm showing you this is they gave 5-FU, then chemoradiation with 5-FU, and followed by 5-FU, and then the same thing, gemcitabine, chemoradiation, then gemcitabine. But the issue was here with the radiation, and what we realized is that when you do radiation, you have to look not only at whether it was done or not, but actually the quality of the radiation that's given, because there can be quite, and David mentioned this, one of the things that I've been very interested in over the years is how do we standardize and improve the quality across the country in terms of how we're doing radiation therapy, because it's a little bit like surgery. You kind of have to know what you're doing, you have to understand the anatomy, you have to understand the drainage patterns, and you have to understand the potential risks and the structures that are very sensitive to radiation. So what I really wanted to show with this study was that, in fact, there was no benefit of either of those. There was no difference between the two chemotherapy agents in the outcome for these patients. But this is just showing there's no difference in overall survival, but just a trend for the improvement with the gemcitabine arm in the pancreatic tumors. And they did find that the local recurrence rate was close to 30%. So even with surgery and adjuvant therapy, there's still about a 30% local recurrence rate. So it's truly an important problem. But even more than the outcome of the gemcitabine versus 5-FU in terms of overall survival, the RTQA score was actually significant for survival for patients on the study. So if you were treated per protocol versus not per protocol, so all of these studies all of the radiation fields were sent to a central site for review, but they weren't actually reviewed until after the study was done. And they found that almost 50% of the treatment plans did not meet protocol requirements for various reasons, whether it was they were treating too large of an area, they were treating too small of an area. And they found that this issue of whether it was based on if the treatment was per protocol versus not per protocol not only impacted on the survival, but also on the toxicity. So there was higher toxicity rates in the patients that were not treated per protocol. So I think you can really see, I think that's something that's incredibly important. And when we're asking these questions is we can't just say, okay, well, we're going to give radiation and we're doing these big studies. We can't really say if it's going to be helpful unless we do high quality radiation. So one of the things that I've been very involved in with developing this next study that is really asking that question about what's the benefit of adjuvant chemoradiation is to make sure that all of the radiation plans are reviewed prior to the delivery of the radiation centrally. So myself and my colleague are reviewing all the plans, and we made sure that all of these, that we have a very strict guidelines and even an atlas to show how the radiation treatments are supposed to be done and how the contouring is supposed to be done, and I'll show that in a minute. But this is now the ongoing RTOG 0848 study, which is a phase 3 randomized trial looking at two questions. One was the addition of erlotinib plus gemcitabine in the adjuvant setting, and then the question of using chemoradiation or not. And so this is the schema. Patients with pancreatic head tumors are randomized. The initial part of the study was randomizing them to gemcitabine alone versus gemcitabine plus erlotinib. That has since been closed, and now patients can go on to study with gemcitabine with any pretty much other approved drug for pancreas cancer. Right now it's usually gemcitabine plus capecitabine. And then they can get enrolled on the study, and then after 5 cycles of gemcitabine, which makes it's about 5 months, they have to go through a reevaluation to make sure that there's no progression, and then they get randomized to just continuing with the chemotherapy and finishing the 6 months, or getting the last month of chemotherapy and then getting chemoradiation. And so this study, as I said, all of the radiation fields are being submitted. We have this online contouring atlas where this is actually what's visible online. We've asked people to contour specific structures in the adjuvant, so primarily vasculature, which is pretty standard. In the post-op setting, you can actually find most of the vessels. But the hardest thing is really that after a surgery like a Whipple procedure, which is the big surgery they do for pancreatic cancer, head of pancreas cancers, everything's moved around in the abdomen, so it's not really clear where to find things. So we've had some issues with, when people submit things, we're asking find where the pancreas is now connected to the jejunum. And that is not always that easy to find. So we've been helping by, sending things back, asking people to contour things. And I think there's partly, as process of doing this, we're educating our colleagues in the community who may not be seeing these patients routinely. And then we after some studies, we figured out what some standard expansions would be on these vessels. And then when you add everything all together, you get a radiation field that really covers all of the areas that we want to cover, which are primarily where the tumor was, the lymph node regions, and sort of the edge of the pancreas where the tumor was resected, which were the highest risk areas for recurrence. And this is what a radiation field essentially would look like, treating the lymph nodes in the hilum of the liver, around the aorta, and where the tumor was. So far we have about 600 of the 900 patients that we need for the study accrued. This question of the erlotinib, plus or minus erlotinib, it was analyzed and it's going to be presented at ASCO in June. But we still need to complete accrual to get that final question of the radiation benefit. And so we've slowed down on accrual. So I'm trying to go, out to other places around the country. We just came back from the RTOG or NRG meeting and discuss this more in detail about trying to get people to come to enroll patients on the study. And we do have it open here, so I'm trying to hopefully get some patients on the study. Our problem at University of Colorado is that we tend to see patients with resectable disease who have maybe something that elsewhere they would have said, okay, we'll take them right to the OR. But here, if it's even touching a vessel, the tumor's touching a vessel, we tend to go with neoadjuvant therapy up front. So our practice is a little different now because we have an emphasis on doing the therapy before the surgery, so then the patients are not eligible for the study. So moving on to the role of radiation in the locally advanced pancreas cancer group. So this has also become controversial of late because of conflicting results of randomized trials. And the thought was for many years that because you could address this local disease burden, you could potentially impact on survival. But that didn't actually play out in one of the recent studies that I'm going to talk about. So as I mentioned, the other options could be that we could at least help with obstructive symptoms and improve quality of life, and then the minority of patients who go for resection. So I'm just going to review two of the main studies more recent studies that have looked at chemoradiation versus chemotherapy alone for locally advanced pancreas cancer. This is a study, an ECOG trial that randomized patients with locally advanced disease to gemcitabine alone or a long course of chemoradiation to a total dose of 50.4 gray. So this is about 5.5 weeks of treatment with low-dose gemcitabine and then additional gemcitabine afterwards. And there was a significant benefit in the overall survival for patients who received the chemoradiation. So this sort of led us in the direction, okay, that seems like the right thing to do. There was a little more toxicity with chemoradiation, but it was acceptable. Well, then, this was a study that was designed in France, and this is a really large multi-institutional study that was, again, looking at the same question, but in particular, they wanted to look at whether we can actually give the chemotherapy first and then weed out patients who might progress, because about 30% of patients who have locally advanced pancreas cancer within about 3 months will declare themselves with metastatic disease. So we wanted to remove the group of patients that had potential to become metastatic quickly. So they gave 4 months of gemcitabine and then reevaluated, and they also had this erlotinib question in there, but we'll give you that actually was a negative. That was actually did worse with the erlotinib. So that's actually one of the reasons we dropped it from the RTOG study. And then the second randomization was either to just the completion of chemotherapy or chemoradiation. And so this dose in this study was 54 gray, which is very similar to the 50.4, and they gave capecitabine, which is a 5-FU oral drug with the radiation. So a very standard treatment for pancreas cancer. And interestingly, there was no difference. The median survival for the chemo alone arm was 16.5 versus 15.3 months, so no difference. What was sort of a positive thing out of all this was that we actually did better than anybody anticipated. When they originally designed the study, they thought that the median survival would go from 9 months for locally advanced disease to 12 months. So clearly in the time between when the study was initially designed to when they actually performed the study, we've actually seen some improvements in our ability to treat pancreas cancer. Some of it may just be do a better job of imaging, and so we weeded out more patients that had metastatic disease. What they did find when they looked at things like progression-free survival was that there did seem to be a trend toward an improvement in progression-free survival for patients who received chemoradiation versus chemo alone. And they also found that the site of first progression for the chemoradiation arm was less likely to be local versus metastatic. And so that's, you would think, because we're addressing the local disease there. The other thing that they found was that there seemed to be a longer time to initiating second-line chemotherapy for patients that receive chemoradiation. So there's some potential benefit in terms of quality of life if you can keep people off chemotherapy for a longer period of time. So there's still some question about how to, is this truly a negative study? Are we just should we be, identifying patients who may still need radiation for certain symptoms or who have been, without evidence of distant spread for a long period of time on chemotherapy. So it's still completely, it's not completely, thrown out the window, although there are a lot more people saying, well, there was no difference in survival for pancreas cancer with the addition of chemoradiation. So why was LAPO7 negative trial? We really were I think most people were pretty surprised in the pancreas cancer world. One of the things that might be an issue is that we were using gemcitabine as our systemic disease, and so that was not the best regimen for controlling the systemic disease, so that in that situation, if the systemic disease is not well controlled, then the local control is not as important. The other question is pancreas cancer just a really radio-resistant tumor? We don't really understand what the true radiosensitivity of pancreas cancer is. We know that it tends to be a very desmoplastic tumor. There's a lot of fibrous cells, not a lot of, actual tumor cells when you actually do a biopsy. So is there something about this tumor microenvironment that makes it more resistant to radiation? There's also a lot of hypoxia. It's known to be a hypoxic tumor, so low oxygen in the tumors, in the center of the tumor, and that could also affect our ability to have efficacy of the radiation. We know that tumors that are hypoxic are less sensitive to radiation. So then the question comes up, how can we use radiation more effectively in locally advanced pancreas cancer? So now we have some new agents and new regimens for pancreas cancer. So if we integrate radiation in some way with these more effective agents, can we now potentially see an improvement in outcomes? And also, what are some ways we can overcome this potential radioresistance? Can we use some alternative mechanism of cell death, such as ablative radiotherapy or as SBRT, which I'll talk about, and also address tumor hypoxia? Are there ways we can treat both the hypoxic and the oxic components? I just want to point out two studies because there have been some things that have had good news in pancreas cancer over the last 5 years. These are two studies that came out within a pretty close period of time. This was a French study that was for advanced pancreas cancer, looking at gemcitabine versus a new combination of pretty much everything in the kitchen sink, which is FOLFIRINOX. And they found that there was a significant benefit in overall survival for advanced pancreas cancer. These are mostly metastatic patients with the FOLFIRINOX, 11 versus 6.8 months. So this is one of the new standards that we use for patients with advanced pancreas cancer. The second big study that came out was this Gem-Abraxane trial, and this came out within 2 years, and we sort of knew about both of these studies around the same time. Again, for primarily metastatic patients, they were randomized to either the combination of nab-paclitaxel or Abraxane, which is just albumin-based Taxol, and then versus gemcitabine. And we did find, again, an improvement in overall survival for patients that received the Abraxane versus the gemcitabine alone. So I think this is really showing us that there are some new agents that are coming out, new regimens that may improve systemic control, and now we need to start thinking again about local control. So let me move on now to SBRT for pancreas cancer. And I know we have a lot of radiation oncologists here, but I'll just try to go over what is SBRT. And really, the idea here is that typically radiation is given at a small dose each day over a long period of time because we want to minimize the toxic effects on normal tissues. But if we can really hone in and just deliver the high dose to where the tumor is and minimize the dose of the normal tissues, then we can deliver these higher dose per fraction without causing more damage to normal tissue. So really, the whole idea is delivery of higher doses in fewer fractions, and this is really predicated on technology improvements, such as the ability to do image guidance during radiotherapy. So we have now diagnostic quality imaging right on the linear accelerator, and we can even perform what we call a cone beam CT scan, but it's sort of a CT scan that can be done on the linear accelerator, and we can see 3D tissue on the scans and be able to make sure that when we deliver the radiation, we're actually hitting the right spot. The other thing that we have to take into account when we're doing this very focused radiation is that everything's moving in the abdomen as patients are breathing. So we have to have a way to take into account respiratory motion. We have to have a technique to do that, and I'll talk about some of those techniques. And really between this image-guided radiotherapy and motion management, we're able to give this much more accurate, precise delivery of radiotherapy. That allows us to minimize the margins that we would give for setup error and motion, and that subsequently reduces the normal tissue doses and potentially normal tissue toxicity. So that's really the idea behind this SBRT. So what are some advantages about SBRT for pancreas cancer in particular? Well, I think it's a really nice option for pancreas cancer because if your life expectancy with locally advanced pancreas cancer is relatively limited, given what we know, spending 6 weeks of your life coming in for daily radiation is a lot, and it's pretty toxic during treatment. People are nauseous, have nausea, vomiting, and sometimes even diarrhea. So it's not an easy treatment. Whereas SBRT is usually given anywhere from 3 to 5 treatments over about a week to a week and a half. There are fewer acute complications. Patients tolerate it quite well. And the nice thing, I think, in particular is that during the long course chemoradiation, we have to give lower doses of chemotherapy when we're giving it with the radiation because it's really not a systemic effect that we're trying to achieve. It's more to radiosensitize the tumor cells. So that doesn't have as good of a systemic effect. And I can tell you that some patients that I've treated with chemoradiation with pancreas cancer, they finish their chemoradiation, they get their first post-treatment scan, and they already have metastatic disease. So the idea is that with the SBRT is you give this short course of radiation. You're not getting any chemotherapy during that time, but you can give more aggressive chemotherapy right up to the SBRT and right after. And finally, the other thing that I think is interesting about this approach is that there actually may be this alternative mechanism of action of SBRT that may overcome the typical radio resistance that we think may be associated with the conventionally low dose per fraction every day. And this is some work that was done when I was at Memorial Sloan Kettering. And this is still not, it's a hypothesis, but there's been some legs with this, and a lot of people think this may be potentially a different mechanism with the higher doses. So when you usually we're giving 180 centigrade per day or 200 centigrade per day. When you give these higher doses of 800 gray or 800 centigrade or higher, you may actually not be killing cells by the typical mitotic cell death, which is where the small doses of radiation cause DNA damage and then the cells die when they're trying to divide. There may be actually an impact more on the endothelial cells of the vasculature feeding the tumor. And when you give these higher doses per fraction, you get this rapid apoptosis of the endothelial cell, and you get a change in the blood flow to the tumor, which may actually be what's then causing the tumor cell damage and ultimately death. So this is, again, not proven, but we're starting to look at ways to assess this. And I'm going to show you in a little bit some of the studies that we're doing to help understand perfusion after high-dose radiation. So the idea of using SBRT for pancreas cancer was really developed at Stanford. And when I first started, my first job was at Stanford. The first couple of years I had faculty were at Stanford. And this was really the beginning of this whole idea of using this high dose per fraction. And we went straight from doing daily 180, 200 per day to doing 2,500 centigrade in one fraction. So it was a big leap. And I can tell you, I would go home and I couldn't sleep at night because it's just treating that, and you have to be so accurate. And we did find that by giving this, we started with this was started before I got there, but they were doing a dose escalation trial, but 25 gray in a single fraction. They saw that in this group of patients, there was a median overall survival of 11 months, and these were all patients with locally advanced disease. But there was some toxicity with that. And as we went on, this was actually doing a combination of standard fractionation to a larger field and then just boosting the tumor. But we saw that there was a lot more toxicity with this, and the median overall survival was only 8 months. And then this is the most recent study that was, again, just the 25 fraction in 25 gray in one fraction, and we had gemcitabine before and after, and the median survival was 11 months. And again, there was a lot of toxicity associated with this, so we kind of took a step back with doing it that way. Simultaneously, over in Europe, a group in Denmark was looking at SBRT for pancreas cancer, and they did 15 gray times 3, so 45 gray total. And they were treating relatively large fields. So they were doing the tumor plus another expansion for edema, and then about 10 millimeters superior and inferiorly to adjust for motion. These were big fields. So what they found was that this was not tolerable. The 1-year overall survival was only 5%, median survival was 5.7 months, and 79% of the patients progressed to greater than or equal to grade 2 toxicity within 14 days of SBRT. So over in Europe, they sort of said, no, we're not doing this anymore. They kind of walked away from SBRT as a whole continent, practically, for at least some period of time. Based on the work that we did at Stanford, we looked at the dosimetric predictor, so looking at what doses to what part of the, say, the duodenum. One of the biggest toxicities with treating the pancreas, as I said, the duodenum is sitting right around the pancreas, is that people were getting terrible ulcers and bleeding ulcers, even death from bleeding ulcers. So we realized that we really need to figure out how to limit the dose to the duodenum, and that's what led to some of the improvements in our ability to deliver radiation, is putting on some dose constraints. So these are just some of the data that came out of a study looking at what were the predictors for grade 2 to 4 duodenal toxicity. So when we developed the next protocol, by this time I had moved to Sloan Kettering, we decided to do a different fractionation scheme, so not that 25 gray in a single fraction. We were going to do 5 fractions, and we did some calculations to kind of come up with a what we call a biologically equivalent dose of radiation if we gave it in 5 fractions versus in 1 fraction. So that came out to be 6.6 gray times 5. And we, again, flanked this with gemcitabine before and afterwards. And it was a study that was a multi-institutional study with Johns Hopkins, Stanford, and Memorial. And this is what an SBRT field looks like for a patient with pancreas cancer. So this is the tumor. It's kind of outlined in pink. And then the dose is this 100% line, and then the dose drops off pretty rapidly. So you're getting your stomach, intestines, you're getting minimal dose to the normal organs. Again, you can see here, it's very nice dose delivery to the tumor and dose fall off around the tumor. And with this, and we had very strict criteria for the dose constraints to all of the normal organs based on what we had done with the Stanford data, which was quite conservative because that was based on what we did with the single fraction. And we could, as you fractionate, you get fewer toxicities as you fractionate. So very conservative dose constraints. And so it was very well tolerated. We had a median survival of about 14 months. And the acute GI toxicity was relatively minimal. We had 2 GI bleeds in all of the 49 patients. And for the most part, people tolerated it very well and actually seemed to have some improvement in their quality of life. They certainly did not get worse between the pre and post as they had done in that Danish study. And see, these are just some of the more recent studies. I'm just showing a smattering of some of the more recent studies that have been done looking at using SBRT for pancreas cancer. And for the most part, the median survivals are looking much better, out to even 20 months. And in this study, they were even using it as pre-op for patients that had borderline resectable patients. And very, very minimal toxicity. Our study had the 8% late grade 3. So I think as of now, I would say that more and more this is becoming somewhat of a standard approach for patients with locally advanced pancreas cancer. We still don't have a study showing that, head-to-head with chemotherapy versus SBRT, although Stanford is looking at, they are accruing to a study looking at that. But I think at many institutions, I think if you have a more dedicated person that does pancreas treatments, it's certainly being done more frequently. I think it's still something I wouldn't necessarily do at any community setting if they're not used to doing, because as I'm going to show you, there are a lot of technical challenges. The use of radiation in the borderline setting has also been assessed, and this is a study that was looking at using FOLFIRINOX and then long-course chemoradiation followed by surgery for borderline resectable patients. I just wanted to point this out because A couple of things. There were about 13% of the patients who got FOLFIRINOX and chemoradiation that had a pathologic complete response, meaning when they went in, took the tumor out, there was no cancer left. So we know that there's some efficacy to using radiation for pancreas cancer. But what's even more important, I think why I think this neoadjuvant approach is so nice, is that a third of the patients who were on this study didn't get their post-op therapy. So it really emphasized how much better it is to give it in the neoadjuvant setting, because then you know patients are going to get their systemic therapy, whereas if you do it in the post-op setting, many of them are so sick they can't tolerate it after a big Whipple. So this study has just opened. It's an alliance trial, one of the cooperative groups, looking at now, instead of using that longer course of 50-40 Senegray, they're using actually SBRT. And there's some different ways to deliver it, but they're randomizing patients to either FOLFIRINOX alone or FOLFIRINOX plus radiation and then surgery. And so this study just opened within the last few months. So we'll hopefully see some more answers as to whether this is an approach that's acceptable for borderline resectable patients. Now, this is our own data. So I just want to say this is one of our surgical fellows who put this together, because we have been really at the forefront of using SBRT in the neoadjuvant setting. Most places are not using it as routinely as we are. So this, one of the surgical fellows looked at our experience with using SBRT versus standard long course chemoradiation using what we call intensity modulated radiation therapy, or IMRT. That's just our sophisticated software to make the long course radiation fields very focused. In any event, what we found was that there really was no difference essentially between the groups in terms of whether they went to surgery or not. These are borderline patients, so that wasn't always clear that all of them would go to surgery, because even if the surgeons didn't always feel that they would be able to do the surgery. The only difference now is that in the more recent group, we're using more FOLFIRINOX, so the SBRT group is more recent. But what I think is most important is that there's always been this fear about using that high dose per fraction radiation before surgery, because it might impact on surgical complications. And what they found was that there was no difference in blood loss, operative time, post-op pancreatic fistulas, abdominal abscesses, wound infections, or length of stay, and the 90-day mortality between the two groups. So it seems that the SBRT doesn't increase risks. And what we found was that so far, this is very early follow-up, there was 11th-month median survival in SBRT group and 15 months in the IMRT group. So this goes along with some of the data that's also coming out looking at using neoadjuvant therapy for all of our patients with pancreas cancer, both all resectable and locally advanced patients, that you probably can see these are the median survivals for these different groups. So if you have a locally advanced patient gets neoadjuvant therapy and then is able to undergo resection, that's about 30% of patients, their median survival is much better, 20 months. With resectable disease, there was a slight, sort of a suggestion that there might be an improvement in the median survival if patients got neoadjuvant therapy, is 23 months versus 20 to 23 months on the adjuvant. Hard to say, but certainly suggesting that maybe the best option is to give it in the beginning. So what are some of the technical challenges with giving SBRT? So one of the things that's a problem with treating anything in the abdomen is you have a lot of organs there. You have a pancreas tumor, which is often very infiltrative, hard to see the edges. This is a typical pancreas tumor where you really can't see, I don't know if that's visible up there, but you really cannot see the borders of this tumor. The other thing is that patients are breathing, their liver is moving up and down, all their other abdominal organs are moving. Your GI luminal organs, like your stomach, your intestines, day to day have different filling depending on how much gas and food. And then also just the bony anatomy, everything moves with respect. Your intestines are moving around all the time. So there's just not very, reproducible setup from day to day. So this is really important when you're trying to treat something very focally and you don't want high dose to go to normal tissues. So we've been able to incorporate a lot of novel physics techniques. And I see some of our physicists here because they've been incredibly helpful with, improving our ability to deliver radiation for pancreas cancer. So how can we continue to give those high doses without causing more toxicity, especially to the duodenum? So one thing that's changed over time is that we've gone from very, like 2D radiation where it gave treatments from the front and the back, and just block things, and you got everything in between getting treatment. Then there was 3D radiation, where you gave the radiation from multiple different fields, all converging to give a high dose. Then there was IMRT, which is you're giving multiple fields and modulating the dose as it comes in so you can get more focused. And now we have something called VMAT, which is basically arc therapy. So the radiation dose is being delivered as this machine is moving around the patient 360 degrees, and it's a very, very tiny dose as it's going around, but all converging to give that high dose where the tumor is and limiting the dose to the normal tissue. So I think that's been a really nice option for SBRT. We also have to make sure we're hitting the right spot. So we do the cone beam CT scans before we treat the patient, line everything up. But like I said before, sometimes it's hard to see a pancreas tumor, especially because we're not giving IV contrast at the time of the treatment. So we really rely on fiducials. And then during treatment, we want to make sure that we're treating we're taking into account the motion. So there are various ways that we can take into account motion, and I can even take images during treatment to make sure that every time I turn the beam on, we're hitting the right spot. And I'm going to show you all of that. And this really comes down to the issue is that we have to make sure we're hitting the target. And this is, all of this work is just trying to make sure we're accurate with hitting the target. So here are the fiducials. We usually use these little Visi coils. You can see it there. Or sometimes some little gold seeds. And these are placed usually by our gastroenterology colleagues through endoscopy using ultrasound guidance, and they place these little gold seeds in. This is what it looks like on an X-ray. So it's EUS guided. And then I can decide between my motion management techniques. The most common types that we use here are either respiratory gating, which is basically just turning the beam on and off during certain times during the breathing cycle, so you always catch the tumor in a certain position. So usually when the patient's breathing out, the tumor is up higher, and that's more reproducible, so that's when we turn the beam on. Or abdominal compression, where we use this belt to compress the patient's belly, and it prevents them from taking big breaths, so we can minimize the excursion of the tumor. So with respiratory gating, we only turn the beam on when the patient's breathing out. We can track the patient's breathing by this little marker on their chest wall that moves up and down and has an infrared marker on it. We have a camera, and we can see that the patient is breathing, and this is in inspiration and expiration, inspiration, expiration, and we set the bar to turn on only when they're at expiration. And we did some work looking at modeling how well this works in terms of minimizing the motion, and what we found was that for patients who, the primary motion is supine, there's a little bit ant pose too. If you were to just treat throughout the breathing cycle, the tumor moves about a mean of 1.34 centimeters. So that means you have to add that margin to make sure you're always catching it, at least that. When you just turn the beam on during expiration, then it only moves about a half a centimeter. So then you can really make sure that, just by adding a half centimeter margin, you can always catch the tumor in that position, within that field. This is what the abdominal belt looks like that compresses the belly. And we looked at the use of the abdominal belt at Memorial Sloan Kettering, and we found that you could reduce the craniocaudal or sup-inf motion to less than 5 millimeters in the vast majority of patients. So here's, this is looking at the with pneumatic pressure or without pneumatic pressure. And so the vast majority of patients had motion less than 5, these are the 5 millimeters down here, whereas without pneumatic pressure, we were getting to almost 2 centimeters motion. The other thing that we do is we make sure we get something called a 4-dimensional CT scan during our simulation, our planning session for the radiation. And this allows us to take multiple images throughout the breathing cycle when the patient is lying on the table, and then we can reconstruct it afterwards and watch a little movie of the patient's breathing during, oops, let's see if that goes again. You can watch this thing moving up and down. You can see these are the fiducials, and you can see that they move up and down as we go, as he's breathing. And so you want to make sure that you're only delivering during a period of time when those fiducials are staying within the area that you want to treat. Then during treatment, we can actually take images with cone beam CT scan. So this is a cone beam CT scan. In these diagonals here are the cone beam. This is the CT scan that was done at the time of simulation that we did all the planning on. And here's the fiducial, and we can line that up to make sure that when we deliver that radiation, it's actually hitting the spot. And this is what an image looks like when from the CT scan. It's called a digitally reconstructed radiograph. And then when we take a regular X-ray film at the time of treatment, we can make sure, again, those fiducials are lining up with where they're supposed to. And even during treatment, I can continue to take images throughout the treatment to make sure that each time I turn the beam on, these little fiducials are going into this area that I demarcated, that is where they're supposed to be when we turn the beam on, so that we can make, if there's any problem, the patient coughs or does something or changes their breathing, we can stop the treatment and make sure that we get them into the right position. So what are some next steps? I think one of the major things we need to do is really establish the appropriate dose per fraction and number of fractions. We've been all over the place, 5, 1, others have done 3. We need to look at what are some biomarkers to help us predict treatment response, and then combination with other therapies. So we have, this is a study that I developed at Sloan Kettering, which we're actually doing the same thing here, except that we're not doing MRIs, we're doing CT scans. We're giving induction chemo for 4 months with either FOLFIRINOX or Abraxane. We evaluate for whether they have distant metastases. If they don't, then they can be enrolled on the study, and they get 3 fractions of SBRT. We get a baseline, what we call a dynamic contrast CT scan that looks at the perfusion of the tumor. Then, after the first fraction, we get a second perfusional CT within about, we're trying to get it within 30 minutes to see if we can identify that change in the perfusion after the high-dose radiation. And then 6 weeks later, we get a repeat scan. And we're looking at using 3 fractions, and we're starting at 9 gray, going 10 gray, and then 11 gray times 3. And the idea here is it's a phase 1 study, so we're looking at the maximum tolerated dose. But there are a lot of secondary objectives, in particular looking at using these new imaging techniques, whether it's the dynamic contrast MRI, diffusion-weighted MRI at Sloan Kettering, or dynamic contrast CT, enhanced CT here, to predict treatment response and also evaluate for gastrointestinal toxicity, because we can look at the normal tissues on the scans and see if there's any indications based on the CT scan that they might be at risk for having an ulcer. So I'm going to just jump through here. So really, we're trying to find biomarkers using imaging to help us predict both response and GI toxicity, because potentially we could even adapt our radiation during treatment. So this allows for adaptive planning. Maybe we change the dose that we're going to give, or the number of fractions, or modify the plan to impact on either toxicity or improving local control. Another thing that we were working on when I left Sloan Kettering was using a drug that's a hypoxia activated prodrug. So this drug called TH302, or ivafosfamide. We know that pancreas cancer is a hypoxic tumor, and the radiation is very good at treating the oxic components, but not so much the hypoxic components. So we had looked at combining this drug, TH302, with our SBRT, and these are just the growth delay curves in our orthotopic pancreas model in nude mice, and we found that the growth delay curve was significantly better when we combined the two versus either the radiation alone or the TH3 alone. So this was certainly very interesting. We've been talking to the company and seeing if we can move forward with that, although they're having some issues right now, but hopefully someday. And then finally, we can't have us talk about cancer now without talking about immunotherapy. I just want to say a few words about combining radiation with immunotherapy. We know that radiation has immunomodulatory effects from several mechanisms, and there are some nice preclinical data suggesting that radiation increases PD-1 expression in mice, so that if you do PD-1 blockade plus radiation, you can get a greater decrease in tumor volume than either radiation alone or with just one of the PD-1 or PD-L1 inhibitors. And the increase in PD-L1 on tumor cells was the dominant resistance in one of the studies to radiation and anti-CTLA-4 therapy due to T-cell exhaustion. So if you do dual inhibition, both CTLA-4 and then the PD-L1, because you can block the PD-L1 expression with the PD-L1 inhibition, then you can really get this pretty impressive cell kill with the combination of all three. So that's very exciting. The thing that we do worry about, though, is that radiation can be immunosuppressive to lymphocytes because they're very radiosensitive. And there have been some nice studies looking at the impact of radiation-induced lymphopenia on survival. And this is a study combining a bunch of different cancer types that were treated with chemoradiation. And they found that 2 months after chemoradiation, 43% had developed severe and persistent lymphopenia, and the patients who had this grade 3 or 4 lymphopenia had a higher risk of death. So that was these patients here in red. But SBRT may not be as immunosuppressive because there's a lymphocyte sparing effect. It's a very focal field. What this is just showing is that with SBRT, the percent of the blood pool that's getting this dose that's potentially effective for killing lymphocytes is much lower than if you treat with a big, large field using the standard IMRT fields. So this is data from Johns Hopkins showing that, again, patients who had chemoradiation standard versus SBRT had a much lower rate. The SBRT patients had a lower rate of severe lymphopenia 1 to 2 months out. And again, those patients who had the lower lymphocyte counts had a worse outcome. So I think this certainly gives us food for thought that SBRT is probably a really nice combination with immunotherapy for patients with pancreas cancer rather than other approaches with larger field radiation. So just bringing this to closure, I just took a few take-home points. For resectable pancreas cancer, the role of adjuvant radiation is still being evaluated, but hopefully we'll finish this trial and within my career, hopefully by the next couple of years. And then for borderline resectable pancreas cancer, there's been this emerging role for SBRT in the neoadjuvant setting, and we're using this really routinely here, one of the few places, but it will be tested more formally in the Alliance borderline trial. And for locally advanced pancreas cancer, I think we've really come to the conclusion that this long-course chemoradiation approach is not the right approach for most patients. We know this from the LAP-07 trial, and generally, just from the logistics of making a patient go through that, I think it's a lot. It did seem that there was a potential progression-free survival benefit, but I think giving radiation another way is the right approach, and that would be doing it with SBRT. And so for the most part, it seems that 3 to 5 fraction SBRT is safe and feasible, and it's a really nice local control option for patients who've been doing well on systemic therapy for some period of time. But I think, we may actually be more likely to see a benefit in terms of survival with SBRT when we're combining it with these more aggressive systemic approaches because of the importance of local control in patients that have better systemic control. And I think as we go forward, we really need to design some good prospective studies to look at what should be the optimal dose and fractionation scheme for SBRT, and to evaluate it more closely in even resectable patients in the neoadjuvant setting. And then also this combination with so many of these new approaches that we're looking at, and I think it's really an exciting time to be involved in radiation therapy because, we're sort of, for many years ago, people told me, oh, you're not going to be out of a job because, they're going to cure, they found the cure for cancer, you're never going to have it. But I think at this point, we've really found that there are probably now many, many more opportunities as a radiation oncologist to be involved in improving outcomes, both local disease, systemic disease. And finally, as always, there's always the need to identify biomarkers that can identify who's really going to benefit from our treatments. And there's certainly things out there that have been evaluated. We have nothing that's been really validated as an accurate biomarker for predicting response to SBRT. So thank you all for your attention, and I know I went right up to the end, but if you guys have any questions, I'm happy to take them. Thank you. Yeah.
So give us your perfect trial for pancreatic cancer right now in Colorado.
Well, I definitely think doing the induction period to actually kind of identify the patients who don't progress. So we have to do some kind of induction, whether it's FOLFIRINOX, plus or minus some, targeted agent or a immunotherapy drug. And I'd probably start the immunotherapy drug early on. Then doing a reassessment. If they don't progress distantly, then we could do a more focused approach with SBRT. And then I think potentially some kind of a window trial where we could, add in different, agents, whether it's PD-1, whether it's OX40, various different agents. And at the same time, we have this wonderful, the immunomonitoring group now that we can actually do assessments throughout treatment to evaluate, what is the immune response to these therapies, and also even look at what is, SBRT at different doses. How are we going to impact on the immune system? I think, there's interest in using really low dose or high dose, but nobody really knows what the right dose is. So, to induce the immune response. Yeah.
Great talk. I was wondering if on the trial, are you doing any surrogate blood marker or
We had been, so on the Memorial trial, we were doing biopsies and doing impact to look at signatures, doing more genomics to see if there was anything in particular that might predict for response to SBRT. But right now, the way that the protocol was written wasn't looking at immune changes over time, but we do have some more funding now, and that would be something I'd be interested in writing in, because the next step, as of right now, we have to accrue at least 9 patients to get to that, to see if we get to the MTD. And then after that, I would like to just switch it up and make it more of an expanding to adding new agents, and some of those new agents could be immunotherapy agents.
Thank you so much.
Great, thanks for everybody for your attention. Oh, I didn't even have it on the whole time.